Assalamu alaikum. Today we are going to continue with our hemolytic anemia topic and see what other diseases are there that consist of this phenomenon. The sickle cell disease, sickle cell anemia, as we discussed that different reasons that may cause such damages to the RBCs. Now this is a hemoglobinopathy, that is damage to the cell membrane, sorry, not the cell membrane but the hemoglobin within the RBC. Seen more in Africans, again it is related to something with resistance against malaria. It has been observed. Adult red cells contain mainly HbA, hemoglobin that is, or HbA2, and a very small amount of fetal hemoglobin which can go away. Sometimes hemoglobin C. HbF is most effective in preventing sickling. Why? It has higher affinity of all the hemoglobins to the oxygen. So other hemoglobins attach to the oxygen with lesser avidity as compared to fetal hemoglobin. And a very small amount of fetal hemoglobin is present usually after birth. It decreases greatly. Sickle cell disease is caused by a point mutation, 6th codon of beta globin, well, that is replacement of glutamate amino acid with a valine residue. Again, an amino acid, another one. So it changes the reading, it shifts the reading, shift occurs, and other amino acids are seen later on. Of course, that makes the molecule abnormal. Here we see what happens in sickle cell anemia, sickling, abnormal sickle shaped cells, damaged RBCs, not normal looking RBCs, a lot of variation in sizes. Heterozygotes with the mutation are said to have sickle cell trait. They don't really show the disease. Homozygous patients show the SCD. Okay, so it's not dominant but recessive disease. Usually it's like this. HbS molecules undergo polymerization when deoxygenated. They change their shape. That's why they become elongated and elongated. They stretch out the cell membrane. And when this happens, a lot of times they permanently become stretched out like in needle shape or elongated shapes. And thus sickling of the RBCs is seen. And of course, they are then damaged by the mononuclear phagocytes. They are totally abnormal. So first of all, the red cells convert from a free-flowing liquid to a viscous gel in the cytosol, and HbS starts aggregating in the cell. Later on, it changes the shape. Sickle cell trait, sickle cell disease, hereditary tree. Molecular sound long needle-like fibers. We just mentioned this. Continuous deoxygenation. It causes chronic hemolysis, microvascular occlusions. That is one big problem. Because they are flatter or they're needle-like, well, they can fit more than one into the small blood vessels or capillaries, where they form plugs, prevent effective blood flow, and thus deoxygenation of the tissue also, which leads to a lot of clinical symptoms and damages to the body. Variables which may affect degree of sickling: HbA or HbC. HbC is another kind which is seen in this disease. Here lysine is substituted for glutamate. Okay, so the chance of sickling, C is also less prone to sickling than HbS. HB, of course, A is the normal one. Here's a picture which shows sickle cells coming to almost block the entrance of major ramification in the artery, and thus decrease the amount of movement of blood. Factors that may affect increased mean corpuscular hemoglobin concentration. This increases by due to dehydration. Often, if there is increased MCST, there is dehydration in the cell, which increases the concentration of HP, and so chances of sickling are increased. Acidity or decrease in pH is also being seen to do the same. Transit time is important of the RBCs through microvasculature beds. It is usually very short because it is fluent. Quickly, they just pass through. But as we already mentioned, that in sickling, they can get stuck. They decrease the blood flow of the cells. So this causes again a need for more oxygenation. Well, oxygen is less in the cells, and they start sickling. Again, this also causes inflammation in the tissues. Spleen, bone marrow, and again due to decreased oxygenation, these organs can get damaged. Cells with HPS also show more adhesion proteins. These are seen more so usually in inflammation or inflammatory conditions. So they adhere to each other or inflame blood vessels, again increasing the sickling phenomenon. Polymers, the polymers grow, they practically herniate through the cell membrane. And the cell is being covered only by the lipid layer. This has been seen microscopically. So the cells are heavily damaged, cell membrane. This damage can cause influx of calcium ions, which increase the cross-linking of membrane proteins, one, and they can activate enzymes. They can also activate ion channels that permit efflux of potassium and water, and this causes dehydration, which increases sickling. And with repeated episodes of sickling, red cells become more dehydrated, more dense, more rigid, and become permanently sickled. They will be removed. Permanently damaged cells retain their shape even in normal oxygen tension because their membrane has been damaged beyond repair. Peripheral blood vessels show variable numbers of irreversibly sickled cells in full-blown disease. There will be reticulocytes because in the blood because a lot of new RBCs are being formed. Target cells result from red cell dehydration. However, Jolly bodies, small nuclear fragments are also present in some red cells due to asplenia. Asplenia, we'll see that nuclear remnants because the cells are too quickly coming in, the nucleus has not been totally removed. Bone marrow is hyperplastic due to erythroid hyperplasia. Bone expansion of bone marrow leads to bone resorption, weakens the bone. Secondary new bone formation, so prominent cheekbones are seen, no changes in the skull. True cut in X-rays, we will see that. Extramedullary hematopoiesis can also appear in time. And gallstones break down hemoglobin. Spleen is enlarged up to 500 gram. In the early childhood, there is red pulp congestion. Later, the spleen will be damaged because of consistent anemic and more than that hypoxemic episodes. So the cells get stuck in the cords and sinuses of the spleen, and chronic erythrostasis leads to splenic infarction because it's not getting enough oxygen. Then fibrosis, significant progressive shrinkage of the spleen. So by adolescence, early childhood, small spleen is only left, and this is known as autosplenectomy. Unlike hereditary spherocytosis, where it enlarges in size. Infarctions can occur in other tissues, other organs like the bones, brain, kidney, liver, retina, pulmonary vessels, so it can produce a lot of symptoms. cor pulmonale, fibrosis in the pulmonary blood vessels, right-sided hypertension, leg ulcers. Leg ulcers, why in the limbs? Because there are lesser blood supplies in the distal part of the limbs. Autosplenectomy. This is a spleen actually in the disease sickle cell. It causes a moderate or moderately severe anemia. 18 to 30% hematocrit. It should be over 40%. Reticulocytosis, yes. Hyperbilirubinemia, hemoglobin is lost, yes, in any kind of anemia. Irreversibly sickle cells. Crisis, vaso-occlusive crisis, pain crisis. Wherever there is ischemia, there is pain, and it can cause abdominal pain or bone pains or other kinds of pains in any organ. Episodic hypoxic injuries and infections. Severe pain in the affected region. Bones, lungs, liver, brain, spleen, and penis are most commonly involved. And thus, even in children, painful bone crises are seen, quite common. Another acute chest syndrome, particularly dangerous because it involves the lungs, fever, cough, chest pain, pulmonary infiltrates, of course, difficulty in breathing, lesser oxygenation levels. Fatal cycle of worsening pulmonary hypoxemia, sickling, vaso-occlusive crisis may occur. Less oxygen, again because the lungs are affected. Less oxygen, more sickling, again the lungs get more affected. And this vicious circle causes a lot of damage to many organs and can cause actually death ultimately. Other problems, vascular obstruction, strokes may be seen. That is ischemia or hemorrhage in the thrombosis or hemorrhage in the CNS. So once that actually happens, it will leave behind less or more permanent damage. Physical dormant impairment is seen. Encapsulated organism infections increased because of loss of spleen. 90% of patients survive to age 20, and close to 50% survive beyond the fifth decade. So none of them reach the normal span of life. You can see that, and this is with all the best management that can be offered. So another disease, paroxysmal nocturnal hemoglobinuria, which is not a common one, but it causes damage to RBCs or anemia here and there, now and then. Disease that results from acquired mutations in the phosphatidylinositol-glycan complementation group A gene, PIGA gene. It is an enzyme used in synthesis of some cell surface proteins, phosphatidylinositol. Rare disease, acquired genetic defect. So it's not usually familial, it is mostly an acquired defect. GPI-linked proteins of the cell membranes are deficient because mutations inactivate PIGA and not enough GP1 linked proteins are produced or synthesized. Positive mutations occur in a hematopoietic stem cell. That's why this disease occurs. All the cells have the same problem. Clonal progeny, RBCs, white cells, platelets are deficient GP1 linked proteins. And in three, PNH blood cells are deficient in three proteins that regulate complement activity. So complement is going to come and sit on the RBCs and get them engulfed by the phagocytes. Decay accelerating factor CD55 and membrane inhibitor of reactive lysis CD59. Now this is the one of them. CD59 inhibits reactive lysis in complement, or they accelerate the decay. Okay, now if they are not present, of course complement will be much more active against the RBCs. C8 binding protein. Most important of these three, CD59. Potent inhibitor of C3 convertase that prevents the spontaneous activation of the alternative complement pathway. So, even if somehow complement gets activated on the RBCs, which it can get easily, it is prevented from forming the last membrane attack complex. So they will be lysed or injured by the complement if they can't do so. Pictorial presentation, diagrammatic presentation rather. Intravascular hemolysis is seen in PNH, which is of course caused due to the C5b to C9 membrane attack complex of the complement proteins. Paroxysmal and nocturnal. Paroxysmal, yes, not always. Nocturnal, only sometimes. In only 25% of cases. So when at start they named it, they might have seen those cases where you can see this only nocturnally or at night. Chronic hemolysis is seen without dramatic hemoglobinuria in most patients. Tendency for RBCs to lyse at night is explained by slight decrease in pH during sleep, which increases the activity of complement. Anemia, mild to moderate, not severe. Thrombosis, major cause of death. It can cause thrombosis as an adverse effect. 5 to 10% of patients may develop acute myeloid leukemia or a myelodysplastic syndrome, damaged bone marrow, where bone marrow is affected. Possibly because some time of genetic damage has been done, maybe in addition to this, what we have known in this disease, or this enzyme may have some other roles too. So, this is about PNH. Clinical features: headaches, nausea, cerebral thrombosis, vomiting, MIs, pulmonary embolism, renal failure, erectile dysfunction, deep venous thrombosis, pyoderma gangrenosal infection in the skin, bone marrow problems, anemia, bleeding, infection, abdominal veins thrombosis, which cause severe abdominal pains. Okay, and retinal vein thrombosis, loss of vision or partial loss of vision can also be encountered. Okay, so now we come on to immune hemolytic anemias. Antibodies that bind to RBCs. We actually did touch upon them in the last lecture, and diagnosis depends upon detection of antibodies or complement on patient's red cells. Direct Coombs antiglobulin test is used. So patients' RBCs are mixed with specific antibodies against human immunoglobulins or complement. If complement or human immunoglobulins are present in that mixture, then we'll see agglutination and come to know that it's an immune hemolytic anemia. Cold and warm temperature, body temperature colder than 3 to 4 degrees or 7 to 8 degrees sometimes. Cold agglutination disease, IgM, warm and autoimmune hemolytic anemia, IgG. Agglutination or clumping is seen grossly with the naked eye so that we can know the result of the test. Then there is an indirect Coombs test where patient's serum is tested. So known antibodies are introduced into the serum. Known antigens are commercially available. This helps specify antibodies in patients to particular antigens. This test is more particular, a bit more specific. More than 50% cases are idiopathic, most common form of immune hemolytic anemia. There can be a predisposing factor like a drug, other things in the environment. It is dependent on the predisposition, genetic predisposition of the patient also. IgG antibodies, sometimes IgA. Now IgG coated cells due to some antigen that IgG antibodies thought was not belonging to the body on the RBCs, so they attack the RBCs and the SC receptors on phagocytes then come and eat them up or cause damage. Splenomegaly may be seen primarily in hemolytic anemia is unknown, and Rh group antigens are attacked. Penicillin or cephalosporins antibiotics, that is in larger doses, may cause anemia, but not immediately. In a week or two after administration, to the same period, they just mark the RBCs upon which antibodies come and anemia is caused. Tolerance breaking drugs, methyl-dopa, it also causes anemia, but the mechanism is not known. That's why they're not tolerance breaking drugs. They've broken the tolerance against RBCs of the body immune system. Cold agglutinin, IgM mostly, and lower body temperature, 3 to 4 degrees, 6, 7 degrees below body temperature. So extremities, fingers, toes, etc. Less common and comes with mostly infections, many times infections, mycoplasma, EBV, CMV, influenza, HIV, like fungal and viral infections mostly, or other atypicals. Chronic or idiopathic. Anemia may also occur related to B cell neoplasms. Well, they also cause anemias later on. Complement fixation resultant phagocytosis. Here, complement is fixed in lower temperatures, okay, or IgM, and phagocytosis is seen. So that is about warm and cold. One other thing, trauma, hemolytic anemia due to trauma, stress shear forces straight away, prosthetic valves, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, DIC, SLE, disseminated cancer, as we mentioned, jogging or running continuously, that also causes some anemia, damage to the RBCs. Microvascular lesions, they may cause luminal narrowing when the process becomes chronic due to fibrosis. Fibrin platelets deposited, then there is fibrosis too. And we see burst cells, helmet cells, or schistocytes in such a condition that is due to trauma. Here we can see their type of cells. And with this, we finish hemolytic anemia. See you with another topic. Goodbye for now.